But I have to tell you just a short story because many years ago when Dr. Gene was at Ohio State, we were chatting about an idea that maybe octreotide might have something to do with blood vessels. So we started to talk, and then Gene went to Oregon, and I struck out pretty with a lot of ignorance and said, well, it should be easy. And I looked it up, and the thing you have to do is the egg, the fertilized egg, which has the pellet that the vessels grow as the chicken starts to grow. And you could do it with the fertilized egg. So while Gene was getting placed at Oregon and getting things set up there, I went over to the Department of Agriculture at Ohio State, which is a monstrous city within a city. And I said, well, I need fertilized eggs, you know. And they said, well, he said, we have this one rooster, Big Red. And I said, oh, okay, you know. And he gets a lot of fertilized eggs. So I started to work on them, and I started to look and see, and pretty soon I learned a little bit about how the vessels grow and at what stages, and as you incubate them. And after about 600 eggs, I thought there was something. I told Gene we might have something, and all of a sudden Gene was already doing his homework and actually did it the right way. He was kind enough to keep us in mind when he published the first and most important paper on the vessel inhibition by octreotide, and that has held up and is now very well recognized in the European community with all the seminal work that Gene did. And to me, it's no surprise that the natural, and I can't help but believe that some of the companies were taking note of the work that Gene was doing on the octreotide action on the small growing new vessels, not vessels that were there, but vessels that were growing. And that's the other thing I was going to share. The nature of this neuroendocrine tumor, the very basic nature of it is that it's a very vascular requiring cell/tumor. And now we're seeing the exploitation of it. We used to see it with the angiogram. In fact, the insulinoma was almost always made when they did an angiogram and they saw the classic blush of these vessels. But cells, even into the grade 2 and 3, will have these small vessel growth attractions. And Gene has really worked and exploited that. And this is precisely what we're going to hear about in terms of at least some of the actions of the anti-angiogenics this afternoon. So it's no surprise, but it's something to keep in mind. And that's probably why hepatic arterial embolization works so well, because of the highly vascular nature of the liver metastasis of neuroendocrine tumors. So our first speaker, and we're just a hair late, so a half an hour, we're gonna go from this moment with the regular time for our speakers, so everybody has an opportunity, is Dr. Ed Wolin, who was recently for a long time at Cedars-Sinai and has now gone to the University of Kentucky. And from what it sounded like last night, he hasn't lost a single step. And I think you're going to hear a very wonderful overview from Dr. Wolin. His title is Clinical Trials for Chemotherapy / Biologic Response Modifier Therapy of the Gut based NETs. Dr. Wolin is coming back. Okay. Thank you.
Hi, my name is from Markey Cancer Center at University of Kentucky. I was previously at Cedars-Sinai in Los Angeles and recently relocated. I'm going to be talking to you about clinical trials for carcinoid tumors. It's part of a big subject of clinical trials for neuroendocrine tumors. I'll be speaking about gut-based tumors, the carcinoids. And then Dr. Bergsland, who will be speaking right after me, will be speaking about pancreatic neuroendocrine tumors. So we have it sort of split up that way, although there's certainly a big overlap between the two areas. The first thing I want to tell you is that clinical trials are making all the difference in the world in how we treat carcinoid tumors and neuroendocrine tumors, and what is possible and why people are now living much longer, much higher quality lives than they were in the past. If we think back 30 years ago, we had almost nothing in the way of therapy for neuroendocrine cancers, and there were almost no clinical trials that were done at that time that were large randomized trials. Today, we have many new treatments and many new therapies, many trials have been done, and almost everything that we know about treatment has been the result of these clinical trials. So what I'm going to do today is to talk about recently completed clinical trials, ongoing clinical trials coming up, and clinical trials that are really making a difference. Okay? 30 years ago, standard therapy in many settings was watch and wait, thinking that neuroendocrine tumors are slow growing, they're incurable, so why cause trouble by treating them? After all, people will live for a couple of years without treatment. So surgery can be difficult, it could be risky, it might detract from quality of life. However, when this kind of approach was used, 5-year survival was only 20 or 30%, and 10-year survival was rare. Now, as Dr. Woltering and others have pointed out, in specialized neuroendocrine tumor treatment centers where we have cytoreductive procedures of all sorts, including surgery and embolizations and ablations and systemic therapies, 10-year survival over 50% is expected in the average, and people do much, much better than they ever did in the past. And watch and wait as a standard of care is really an obsolete concept in treatment of neuroendocrine tumors. And in almost everybody, it's not something that would be the way to go when you have a diagnosis of such a disease. Now, just let me give you a brief overview about clinical trials. Clinical trials involve participation in a study where you're able to be treated with a drug, a treatment which is not generally available. To do that, you need to understand the trial in detail. Consent is involved, understanding the trial is involved, and discussion of all other alternatives is involved. So it's a whole process. There are many kinds of clinical trials that range all the way from first in human use of something that looks really exciting that has just been discovered in animals, up to something which is so well studied and been used in thousands of patients and it's almost on the verge of getting approved by the FDA. All of those things are in clinical trials. So it's not just one item or one type of treatment. So what are the advantages to an individual patient to participate in a clinical trial? First of all, it gives access to new drugs and treatments. Right now, there is not a single FDA-approved treatment for metastatic carcinoid tumor, not even one. 30 years ago, there wasn't one. Today, there isn't one. So every single thing that is used is either off-label or in clinical trial. That being said, we have a lot of things that are extraordinarily promising. The results are looking so good that we're expecting approvals to start happening very soon. But if you need to be treated or want to be treated with any of these new agents, the only way to receive them is on clinical trial because they're otherwise not even available. Okay? So this is often the only way to receive cutting-edge therapy. It also is a way of improving clinical care because anybody on a clinical trial has very close monitoring of therapy, knowledge that the treatment that they are receiving has been sanctioned by peers. There's a very extensive peer review process that goes into allowing a trial to be approved for human use. And a detailed analysis of risk and benefit is shared with the patient, so whoever is being treated is fully aware of everything going on. You also have a certain personal satisfaction that comes from the feeling that as well as helping yourself, you'll be helping the world and helping other people. A number of blind men came to an elephant. Somebody once told them that it was an elephant. The blind men asked, "What is the elephant like?" And they began touching the body, what in medicine we call palpation. This blind man had only touched the leg. Another man said, "The elephant is like a husking basket," and he had only touched the ears. Similarly, he who touched his trunk or his belly talked of it differently, but none of the blind men knew more than what they were actually experiencing themselves, which was a very limited part of the elephant. And so these men of Hindustan disputed loud and long, each in his opinion exceeding stiff and strong. Although each was partly in the right, all were in the wrong. You see these 10 men and an elephant. Okay? Just keep this in mind for a second as we move to where we are today, which is 10 blind doctors and a zebra. Okay? The carcinoid patient in the middle is the zebra. Okay? And each medical specialist who's sitting around the table here is somewhat blind to the capabilities of the other specialties, even though they are excellent in their own right. Medical oncologists, experts in systemic treatment, somatostatin analogs, all kinds of systemic management, PRRT sometimes, targeted drugs sometimes, but they're not surgeons. They're not interventional radiologists. Similarly, you have an endocrinologist who's an expert in hormone secretion syndromes, radiation oncology, involved in using radiation as a therapy, cardiology, as we heard earlier today, carcinoid heart disease, gastroenterology, doing sophisticated endoscopic ultrasounds and double balloon endoscopies and other diagnostic procedures Dr. Warner was talking about, pathology to make a proper diagnosis, since you don't even know where to begin if you don't have a proper diagnosis. Again, as we heard earlier today, interventional radiology, doing all kinds of procedures, particularly on livers to get rid of tumors with catheters or needles, diagnostic radiology to interpret MRI scans, CAT scans, and other scans properly, nuclear medicine with diagnosis as well as therapy. And we'll be hearing a lot more about that in this conference, and of course, surgery. In addition to the doctors that are sitting around the zebra trying to figure out what to do, there's a whole group of other individuals sitting around trying to help figure out what to do as well, that include oncology nurses, nurse practitioners, research coordinators, pain management people, psychosocial team, dietitians, complementary medicine, secretaries, techs, pharmacists, registration, blood draws, survivorship programs, schedulers. Everybody the patient comes in contact with is part of the team. A team is only as good as its weakest link. Everybody has to work together. I set up a model like this at Cedars-Sinai when I was at that institution. We now are doing the same type of thing at University of Kentucky, having multidisciplinary management, and it makes all the difference in the world. Okay. I'm going to talk briefly about some principles of management of neuroendocrine tumor, and then we'll talk specifically about clinical trials. The reason that I'm emphasizing the multidisciplinary team and the approach that I just have outlined is that this is the first step in determining who might benefit by a clinical trial, who might not. Not every patient needs a clinical trial or might benefit from one, but if there's an appropriate clinical trial that is something to consider, that is something that can be talked about with patients. But if somebody needs surgery, you get rid of all the tumor, there's nothing left to treat with some chemotherapy, let's say, you wouldn't even have to talk about a chemotherapy trial because it wouldn't be relevant. There wouldn't be any tumor that needs to be treated with such an agent. So everybody has to work together. The basic principles of management are, like you heard, surgery, 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 whenever possible, cytoreduction, get rid of metastases, whether they're in the liver, whether they're in the abdomen, and also use these other types of procedures for reducing the volume of cancer, reducing the number of cells, what we call cytoreduction. Treatment with systemic somatostatin analogs, targeted biologic agents, and chemotherapy, which I'm going to be focusing in most of the remainder of the talk. And also using peptide receptor radiotherapy with targeted radiation. Of course, treatment of patient symptoms, particularly the carcinoid syndrome-related symptoms, are always part of the picture when those are present. A few basic principles about chemotherapy for neuroendocrine tumors that sort of are overarching guidelines of how we think about this disease with treatments. Chemotherapy for neuroendocrine tumors usually do not cause a major reduction in tumor size, what we call a low response rate. There are a few types of chemotherapy, particularly in pancreatic neuroendocrine tumors that you'll be hearing about later, that actually can shrink tumors up. But in general, they stop tumors from growing, and if they shrink, they usually don't shrink a lot. Despite the low response rate, time to progression can be markedly prolonged with chemotherapy, extending survival and increasing quality of life. In general, more metabolically active carcinoid tumors, which are things that are sometimes called intermediate grade or grade 2 or higher Ki-67, and particularly grade 3, these kinds of tumors may be more responsive to chemotherapy than slower growing tumors. Ones with higher Ki-67s may be more responsive. Okay, as I mentioned, there are no currently approved treatments for carcinoid tumor. Pancreatic neuroendocrine tumors, Dr. Bergslund will discuss with you. There are a few things available for that disease. And for high-grade tumors, we have some chemotherapy which can be used with cisplatin and etoposide. We also have some exciting data that is starting to accumulate using temozolomide and capecitabine in various types of neuroendocrine tumors, particularly pancreas, as you'll hear. Okay, now, what kinds of things are available in clinical trials, and why are we so excited? Neuroendocrine tumors have several features that make them uniquely able to be stopped by biologic agents, what has been called biologic response modifiers or biologic agents, things that are different than the normal types of chemotherapy which you might think of for other kinds of cancer, which often cause people to have severely low blood counts and have hair fall out and have a lot of different side effects. Those kinds of drugs don't usually work in carcinoid tumors, but what does work are certain biologic agents. The increased blood vessels and substances that stimulate blood vessel growth are prominently expressed in neuroendocrine tumors and are wonderful targets for therapy. Dr. O'Dorisio was just mentioning that. The cell membranes of neuroendocrine tumors have increased tyrosine kinase growth factor receptors that can be targeted and make the cells not grow so much. The genes involved in maintaining the malignant state are overactive in neuroendocrine cancers, another place where targeted therapy can be administered. Neuroendocrine tumors have lost dependence on external stimuli to proliferate and instead generate internal signals, and sometimes this can be exploited with therapies. They no longer respond to stop growing sort of signals. They don't stick to the membranes that underlie the cells and allow cells to float around and metastasize. There's no limit to the number of cell divisions, and cells can replicate forever, part of this related to the telomere situation that you heard earlier this morning. Neuroendocrine tumors have defective enzymes, which are necessary for cells to commit suicide, so-called apotosis, which is a normal process that happens in cells for the benefit of the whole organism, that when cells are no longer needed, they die. That can be stopped in malignant cells, and we can potentially reverse this with therapy. And there are changes on the surface of cells letting them escape immune destruction, and that's another new thing that's being investigated for therapy. There are mutations in neuroendocrine cells making them resistant to various kinds of chemotherapy, and we're just now learning ways of overcoming resistance. So when you think of all these potential targets and how right now we're sitting in a situation without approved drugs, you can see there's so many avenues for developing things that are new and exciting. And the whole process of trials in neuroendocrine tumors is a little bit more difficult, it's a little bit more time consuming than for common malignancies because it's harder to get studies funded and accomplished. But nevertheless, it's happening, and I think you'll see some exciting new data. One more thing I wanted to talk about is molecular profiling. Again, it's been touched on earlier today. The concept of analyzing the genetic makeup of cancer cells, trying to identify mutations and identify specific treatments that can attack those mutations. There was a study done by Dan Van Hoff with multiple kinds of cancer, not just neuroendocrine cancer, looking for molecular targets by this kind of an approach and trying to guide therapy by this approach. And at least early data suggests that you can have a benefit if you can choose therapy carefully based on this type of analysis. This is just now coming into reality with neuroendocrine cancers. The testing can be done not just from fresh tissue taken at surgery, but can even be done from tissue in the laboratory. But it's still relatively early in development. Tumor specimens removed at surgery are sent for molecular profiling. In pancreatic neuroendocrine cancer, there are 4 commonly found so-called driver mutations that make the cancer abnormal. People are trying to find mutations in carcinoid that are doing the same thing. And for individuals with cancer, it's possible in many cases to identify what would be a promising therapy based on such an assay. I just want to caution you, though, that we still are in the early stages of development of these techniques, and there are several pitfalls which you should be aware of. Using assays which are not adequately validated, and we don't know quite how to interpret them, selecting incorrect patients for treatment, because again, we don't have enough data to know for sure that the treatment is going to work as predicted, increased cost of care. These analyses can sometimes cost a few $1,000s. Logistics involving screening large numbers of patients to identify a rare one who might benefit from a result. And also, most importantly, the targets change over time as tumors grow and metastasize, and what you find from molecular profiling now may be different than what you find in molecular profiling 5 years later. So sometimes that entails additional biopsies to have accurate data, and you don't know for sure that you can rely on what was done in the past. This, of course, raises ethical issues as well, but I just think it's a discussion that we need to continue having and something that you should be aware of. And what do we do with this funny little thing that popped up on the screen? Okay, so the first molecular target I want to talk about is something which has been around for so long that most of you don't realize it's a molecular target. And that is the somatostatin receptor present on the surface of neuroendocrine cells. All right, so what is somatostatin? Somatostatin is a peptide hormone which is nature's turnoff in the endocrine system. It turns off hormone production, it turns off growth of neuroendocrine cells. That's its job, to turn things off. Okay, you eat a candy bar, the body makes insulin to keep the blood sugar from going too high, but you don't want your blood sugar to go down to 0. So somatostatin comes along, shuts off the insulin, and everything's fine. So it has a negative feedback effect. But we can actually use this negative action as a means of stopping neuroendocrine cells from growing. The action of somatostatin is mediated through membrane-bound somatostatin receptors, which are often nicknamed SSTR. These are the spots on the cell membrane of neuroendocrine cells that are able to bind to somatostatin. Somatostatin has a very short time in the body, a half-life of 2 or 3 minutes, making it extremely poor as a drug. Okay, it just doesn't last long enough to be very good. So what has happened is we have somatostatin analogs developed. Somatostatin analogs are modifications of the somatostatin molecule, letting them work for hours or weeks, or sometimes even longer than that. These modifications are the somatostatin analogs. Octreotide, also known as sandostatin, and octreotide or sandostatin LAR, are right now approved for treatment of carcinoid syndrome. There is no official approval at this point for treating carcinoid tumors, although for reasons that we'll see soon, there is some rationale for doing so. Right? They're highly effective in the management of diarrhea and flushing associated with metastatic carcinoid tumors. This is a little cartoon of 2 molecules. The one on the left is octreotide, the one that we use as therapy, and the one on the right is the natural somatostatin. The pink balls, 4 of them, are the so-called binding site, the part that sticks to the somatostatin receptor. And you can see that octreotide, the artificial analog, and natural somatostatin are practically the same. There's one very tiny change in one amino acid. L-tryptophan changed to D-tryptophan is the only change, and otherwise it's the same. But the half-life goes from 3 minutes to 90 minutes, and in formulations like octreotide LAR, 1 injection can last for 4 weeks just by making these little modifications. Okay, now how do we know that octreotide is a good anti-cancer drug? There's a study that was done in Europe known as the PROMID study. In this study, 85 patients with midgut carcinoid tumors were randomized between octreotide LAR, 30 milligrams a month, versus placebo given every month. And the question is octreotide really better than nothing? Does it really stop the cancer from growing? The endpoint of this trial was progression-free survival. How long can you go without tumor progression? The average time to progression was 14 months with octreotide versus 6 months with placebo. A very highly statistically significant number, and more than doubling of progression-free survival time with octreotide, making octreotide look like an excellent treatment for carcinoid tumors and generally well tolerated. The stable disease rate at 6 months was 67% with octreotide versus 37% with placebo. Another somatostatin analog, which has been intensively studied, is Lanreotide. Lanreotide is a subcutaneous sustained release formulation of a somatostatin analog, which can also be injected once every 4 weeks, but as a subcutaneous injection. It's able to give high levels in the blood and potentially very effective doses in a small volume. It's also potentially better tolerated by very thin or malnourished individuals who don't have a big rear end for injecting octreotide LAR. And for people with excessively big rear ends, it allows the medication to be injected in a place where it's able to work well, which is in a subcutaneous location, because if you miss the muscle and you end up with the injection going into the fat of somebody's rear, you can have blood levels which are excessively low and the drug will not be very effective. So these pitfalls of octreotide can potentially be overcome by the subcutaneous formulation. So a study was done which is known as Clarinet. Clarinet is a way of making an acronym by the most peculiar contortions of letters here, which are highlighted in blue, from placebo-controlled study of Lanreotide anti-proliferative response in patients with enteropancreatic neuroendocrine tumors. And if you like playing word search and picking only the letters that you really want to use, you can make it spell clarinet. So this is now known as the Clarinet trial. So what is Clarinet? This was designed to evaluate the anti-tumor effects of the somatostatin analog Lanreotide Depot, 120 milligrams subcutaneously every 4 weeks, which is a relatively standard dose of Lanreotide LAR. It's thought to be roughly equivalent to octreotide 30 milligrams every month. But they're different drugs, you can't directly compare. CT or MRI scans were done to evaluate progression-free survival in 204 patients, randomized between Lanreotide Depot and placebo. So this was a study that was more than twice as big as the PROMID study that was done with octreotide. And in addition, it was not confined to midgut carcinoid tumors, but it was for all kinds of carcinoid and neuroendocrine tumors, including pancreatic neuroendocrine tumors. The progression-free survival in the group that got Lanreotide was 33 months, and in the whole group and in the placebo arm, the progression-free survival was 18 months. So this, again, doubled the progression-free survival. Now, when you look at this and compare it with the PROMID study, you'll notice that the placebo arm on this study did better than the treatment arm on the PROMID study with octreotide. The reasons are complicated, but part of them is the patient selection in the studies, but part of it is the way progression was determined. And in the other study, the criteria for progression were much more rigorous and people were stopped much more quickly for progression than on this study. So we can't compare one to another, but I think that what you could say is that in both studies, the somatostatin analog doubled the time that the cancer was able to remain under control on the average. Progression-free survival means the amount of time that elapses from the time you start treatment until there is documented progression on CT or MRI scan by what is called RECIST, R-E-C-I-S-T criteria, was what was done in the Lanreotide study, and by so-called WHO criteria, which were done in the PROMID study with octreotide, and the criteria for progression in WHO and RECIST are quite different. And we can talk about it later if you're interested, but that is part of it. It does not, it definitely does not mean survival. It does definitely not mean death. It means amount of time that elapses before a new treatment needs to be started. Okay? It's just how long the cancer is stopped in its tracks. Somebody's cancer is growing, and you start a treatment and it stops growing, and it never grows again for 5 years, that's called a 5-year progression-free survival. And in people with slow-growing indolent tumors, where you can live for years and years and years, these progression-free survival periods add up to a really major increase in overall survival. People are able to keep going for a long, long, long time. Okay? In doing these kind of studies, you can't really measure overall survival in a meaningful way because people live for such a long time, the investigators' grandkids will be finishing the study. And in addition, it's confounded by people that when one thing doesn't work, you use another thing, and that thing doesn't work, you use another thing, and you can't find anybody where it's only that one treatment that's the only difference between the groups. So progression-free survival is sort of the surrogate for efficacy on almost all neuroendocrine trials that we'll be talking about. The most common toxicity of Lanreotide was diarrhea in 26% in the Lanreotide group and 9% in the placebo group, approximately the same as you would expect from octreotide. And in many cases, what is called diarrhea is actually something that is the result of malabsorption, so-called steatorrhea, which comes from not having enough pancreatic enzymes, a very common complication of using somatostatin analog therapy. And if any of you are on octreotide or Lanreotide and have problems with diarrhea, especially associated with excess gas, floating or greasy stools or other symptoms that suggest malabsorption, these symptoms can be resolved very quickly in most cases by taking some pills of pancreatic enzymes. So just be aware of that. Other toxicities, again, similar to what you expect from octreotide, somatostatin analogs. If you put the results on a graph like you were used to seeing with progression-free survival vertically and time horizontally, you can see that people getting Lanreotide on an actuarial survival curve were way, way ahead of people who got placebo. Okay, so this is an important drug and potentially will be, I think, practice-changing, especially if it gets FDA approved in the near future. Able to control cancer for all kinds of neuroendocrine cancers. Another somatostatin analog, which is being intensively studied in clinical trials, is pasirotide. Pasirotide has better somatostatin receptor binding than octreotide. There are 5 different subtypes of somatostatin receptor that normal somatostatin interacts with. Octreotide almost entirely interacts with type 2, a little bit with type 5. Pasirotide binds to 4 out of those 5 types. It's generally well tolerated like octreotide and Lanreotide, but it's often associated with a little bit more elevation of blood sugar. In phase 2 trials, pasirotide appeared to improve carcinoid syndrome in octreotide-resistant patients. A large phase 3 trial was done comparing pasirotide with octreotide in high dose. It looked like progression-free survival was 5 months better with pasirotide. It's looking very promising, but it's going to take another larger study to conclusively prove this. And I think we should stay tuned because it's a very, very exciting drug and is being used right now in escalating doses to determine an optimum dose. It's being used in pancreatic neuroendocrine tumors, often with what is hopefully success in controlling syndromes. And it's being used in a variety of situations in neuroendocrine cancer. Another type of drug I'd like to talk about is a so-called mTOR inhibitor. mTOR, M-TOR, is a central regulatory enzyme that's found in cells in the body. But in neuroendocrine cells specifically, there often are mutations in the signaling pathway associated with mTOR. As a result, we have the ability to target this with specific receptors. Okay, so the one which is being studied the most is known as everolimus. Everolimus targets the mTOR receptor, and everolimus plus octreotide in carcinoid tumors appeared to improved progression-free survival by 5 months compared to octreotide alone. To prove the superiority of everolimus to octreotide, another study was done known as RADIANT-4, which compared everolimus to placebo. That study has been fully accrued. In other words, all patients who are going on that study are already on and are doing fine. And when that data is analyzed, we'll have a definitive answer. You'll be hearing from Dr. Bergsland about everolimus and pancreatic neuroendocrine tumors, where data is already more clear-cut. We also are exploring new types of mTOR inhibitors, which are next generation after everolimus. CC223 is one which had a lot of experience with and which is very promising. Anti-angiogenic drugs are worth mentioning. Bevacizumab is a monoclonal antibody to vascular endothelial growth factor. It inhibits growth of tumor blood vessels. It's generally well tolerated, although it can cause hypertension, bleeding, thromboembolic complications, impaired wound healing. And if you don't take care of these potential side effects properly, you could end up with heart problems, as you heard earlier today, although those are rare with careful management. There's a 24% response rate in neuroendocrine tumor, which has been reported. There's a trial of bevacizumab versus interferon alpha in carcinoid tumors, both drugs looking quite good, and that study is remaining to be published. Another drug which has anti-angiogenic properties is a pill known as pazopanib. It's an oral tyrosine kinase inhibitor that prevents growth of blood vessels in tumors by inhibiting multiple vascular stimulatory sites. It inhibits the growth of new blood vessels in neuroendocrine tumors, depriving the tumor of oxygen and nutrients. And this trial is being studied now in carcinoid tumors. Dr. Bergsland, who's going to be speaking next, has also been very much involved with this clinical trial that we're participating in as well. This is a graph of effect of pazopanib in carcinoid tumors, originally from Dr. Fan. Everything below the line is smaller tumor, everything above the line is bigger tumor, and you can see that most people with carcinoid had the tumor stopped in its tracks or even smaller. And this has led to the randomized trial, which is ongoing right now as we speak. Fosbretibulin is a drug I'm very excited about and actively studying. We have right now derived from a natural substance called combretistatin, found in the bark of the South African bush willow. Fosbretibulin, combretistatin A4 phosphate, prevents microtubules from forming in cancer blood vessels and results in rapid destruction of the blood vessels and rapid destruction of tumors. It's a very exciting new drug, depriving cancer from oxygen and nutrients, and can lead to rapid death. The clinical trial is ongoing. Eligibility include metastatic gastrointestinal neuroendocrine tumors or carcinoid, elevation of biomarkers such as serotonin or 5-HIA or any other biomarker that can be measured in the blood, tumor progression in the last year and a half. Everybody gets the drug. It's not randomized and is available now. And the last drug I wanted to talk to you about for treating carcinoid is called telotrestat atiprate. It's a new treatment for diarrhea from carcinoid syndrome. It's looking very promising. An oral medication drastically reduces serotonin production by carcinoid tumor cells by inhibiting the enzyme called TPH that's involved in making serotonin from tryptophan. Minimal toxicity in normal doses, does not affect serotonin production in the brain, does not make people jump off roofs or become severely depressed. And in phase 3 trials right now are ongoing in a randomized study of 2 dose levels versus placebo, and then open label telotrestat for all comers on the study, whether they were randomized to placebo or not. Everybody gets the drug after 3 months, and it's a very exciting trial that we're waiting results for. Those are the things I really wanted to talk to you about today. There's some other things that are closely related, and you'll be hearing about from Dr. Bergsland, since they primarily are being used for pancreatic neuroendocrine tumors. And peptide receptor radiotherapy is dependent on binding to the somatostatin receptor, binding lutetium-177 labeled octreotate to the somatostatin receptor. So that's another targeted therapy based on this type of binding. Gallium-68 dotatate PET scanning or Dotatoc PET scanning is, again, a diagnostic test based on this binding to somatostatin receptors. Somatostatin receptors, just remember those. They're going to be very important, and you'll be hearing more about them in the conference. Anyway, I think my time is up. It's been a great pleasure speaking with all of you, and look forward to continue working with you. Just one more thing I wanted to show you was a picture of California Chrome, who went from California to Kentucky to win the Kentucky Derby. And I feel a little bit like California Chrome going from California to Kentucky to gallop along in the race against carcinoid tumors. And I just wanted to show you my new home at University of Kentucky. Thank you.
Thank you very much, Ed. That was a superb overview with sufficient detail to justify a lot of the newer class that are coming on board and are already on board. So our next speaker